We're also going to switch around the order of two of the talks, so the third talk will be first, and the first talk will be third. So we'll begin with our first presenter, Dr. Tatyan Clarke, is going to be presenting fibrin glue for intraperitoneal laparoscopic mesh fixation, a comparative study in a swine model. Dr. Clarke.
Good afternoon. She mentioned I'm Tatyan Clarke from the University of Southern California. Our only disclosure is the research grant which we received in 2008 for the performance of this study. Laparoscopic inguinal hernia repairs have established fibrin glue as a fixative rather than solely a hemostatic agent. In the intraperitoneal approach used for laparoscopic ventral hernia repair, the tradition mandates a transfascial fixation method, not unlike that utilized with open hernia repairs. The current gold standard is transfascial suture with tacks, although techniques employing tacks alone are becoming increasingly popular. The problem remains that these fixation options are associated with what may be considered an unacceptably high rate of chronic postoperative pain in these patients, which is attributable to the fixation method and site. For this reason, interest is beginning to build in the use of fibrin glue as an intraperitoneal fixation method, although the question remains, what is its efficacy in terms of fixation strength, and what is its propensity toward migration, contraction, and buckling, all of which are factors associated with recurrence. Our study's objective was to test the hypothesis that the use of fibrin glue in laparoscopic ventral hernia repair is an acceptable method of fixation. Using a porcine model, we conducted a prospective, randomized study comparing the four fixation techniques, and meshes were fixed using tacks only or suture and tacks, being the two most popular methods, and they were compared to glue utilizing modalities, including glue alone, as well as the combination of glue with tacks, as shown in the figure. Our study population was 12 pigs, in which 4 6 by 6 centimeter dual surface mesh squares were applied to the midline anterior abdominal wall laparoscopically. All 4 fixation methods were used in each pig, and therefore every animal was its own control, but the placement in terms of caudal-cranial position of each fixation method was randomized. And the corners of each mesh square were marked with tacks in order to demarcate primary location to be used to assess migration at the end of the study. After 28 days, the pigs were euthanized and the meshes evaluated. The tensile strength tolerated by each fixation method was measured and then reported in newtons per meter squared. Also evaluated was the type, extent, and tenacity of adhesions as defined by the adhesion score described by Cristoforoni in 1996. The migration of the mesh from its primary position was assessed and measured in centimeters. Any contraction or change in surface area was evaluated, and any buckling or wrinkling of the mesh was assessed based on this simple buckling score. Our results were as follows. The tensile stress tolerated by the fixation methods were similar, although numerically the suture and tacks method showed the highest tensile strength. When comparing the methods to one another, there was no statistical significant difference. Likewise, adhesion scores were also similar. Of note, the only difference we identified with the extent of adhesions was related to the site of the mesh placement. The cranial position seemed to be associated with a greater extent of adhesions between both the mesh and the fixation sites and the pig's liver or spleen. This was a statistically significant greater extent of adhesions, and of note, the glue-only group did randomize 42% of the time to the cranial position. Nonetheless, this difference did not have statistical significance, and the 4 fixation types are all comparable. In the migration group, however, the suture and tacks group demonstrated no measurable migration, whereas the glue-only group showed a statistically significant increase in migration with a mean migration distance of 3.3 millimeters. There were no differences identified with comparisons to any other group. Likewise, in the contraction group, there was a statistical increase in contraction using glue only when compared specifically to sutures and tacks, and again, no differences compared to any other modality. When evaluating buckling, as seen in the picture here, whether identifying trace, mild to moderate, or significant buckling and giving them a score as shown on the chart. The glue-only method was actually associated with a numerically lesser degree of buckling and folding than any of the modalities involving tacks. This difference, however, was not statistically significant. We were able to conclude that modalities utilizing glue, either glue only or glue with tacks, did show comparable tensile strength to the gold standard of sutures with tacks, although they showed a statistically greater rate of migration and contraction, specifically when glue only was compared to the gold standard. This is obviously of concern because migration and contraction are factors directly associated with recurrence. The long-term efficacy of a mesh repair is related to tissue ingrowth and the integration of the mesh into the abdominal wall. However, short-term success may be attributable to the stability of the fixation method. For this reason, we feel that perhaps a glue and tack method might be an acceptable alternative, as it does minimize the use of tacks, but employing the additional benefits that we discovered in the utilization of glue to minimize any invasive method. Of course, all of these conclusions require further study because the purpose of our study was to identify the efficacy of fibrin glue and did not assess for pain. Further clinical trials, of course, in humans will be more valuable to discover whether or not this particular benefit holds true. Thank you.